So welcome back, guys. This is Dr. Ajinkya here, and today on the screen I'm going to show you the fourth case of my O.P.D case discussion series. As you can see on the screen, this patient's age is old. He's above 60 years of age, and this patient had come to the O.P.D with complaints of left-sided nasal obstruction, left-sided nasal discharge, and he also had episodes of nasal epistaxis in between. Not too serious epistaxis, but mild to moderate intermittent nasal epistaxis, and he had nasal obstruction since a period of around 1 year to 1.5 years. So not that chronic long history, but yes, 1 to 1.5 years nasal obstruction. So judging the patient's age and unilateral nasal obstruction with nasal epistaxis, we had the first thing in doubt was the CA, most probably cancer of the paranasal sinuses or the nose, because of the old age and the history of one-sided obstruction along with that same side epistaxis. So we assumed that this patient may have a maxillary CA or any sinonasal CA. So this was the only history which the patient had, nothing else. But you can see, as evident from the photograph over here, the patient had no left side cheek swelling, no any tooth loosening, or any chronic maxillary pain or any metastasis or secondary mets in the neck area. No lymph node was swollen. Even the the positive signs for malignancy were not seen clinically. So no cheek swelling, no teeth, or you can say tooth loosening, no obvious swelling on the neck, or no any prominence of any facial features, just left-sided nasal obstruction with nasal epistaxis. So the next step we had to do is go for the anterior rhinoscopy, or you can say the endoscopy after proper nasal decongestion. So as you can see, this is the patient's left-sided nasal cavity, and you can see directly on the endoscopy we could see this was the pus discharge. So the patient had putrid nasal discharge along with blood tinged. You can see the patient is actively having some kind of liquid fresh blood. It's not even clotted blood, but it's kind of fresh liquid blood along with putrid secretions in the left nasal cavity, suggesting that this was infective in nature along with blood. And you can see something blackish in nature over here. This could be a part of the mass, or it could be a thick purulent infective secondary mucoid secretion, or it could be just a part of the the nasal mass. So this entirely was covered with blood, tinge of blood, with nasal discharge. And the most important thing to notice here was that this is more towards the floor of the nasal cavity. This is more towards the floor. This is almost the floor, and you can see the middle turbinate right over here. That's the middle turbinate, and this supposed to be the inferior turbinate, the boggy inferior turbinate. So you can see the middle turbinate is being pushed medially towards the septum, being almost compressed by the mass which is coming out in the nasal cavity. So any mass which comes out from the lateral nasal wall or the maxillary sinus will push the middle turbinate definitely medially, and the inferior turbinate will be compressed. So we assume that this could be a case of maxillary CA, but then after the endoscopy we perform the patient's CT scan, which is mandatory. So we have two CT scans over here. One is the coronal section and one is the axial section, as you can see over here. The axial section showed clear cut definite mass of coming from the posterior aspect of the maxillary sinus, which was going towards the nasal cavity, but it had only posterior extension up to the choana and anteriorly up to the middle 1/3 of the nasal cavity. So the anterior 1/3 of the nasal cavity was kind of free according to the axial CT scan, and in the mass we could see some alternate hypo and hyper densities. So this is basically a contrast CT scan, because you can see the blood vessels over here. So that's the indicator of being a contrast CT scan. So this is a soft tissue bony window of a contrast CT scan. So this is how you definitely go for identifying that contrast or non-contrast, because you can see definite blood vessels full of contrast over here. These are the common carotid and the the external and the internal carotid artery at the level of this. So mostly this is the level of the, now this is also the posterior circular villus levels of the artery. So this is a contrast CT scan basically. So this is how you identify that. And so you can see that this is filling of blood in the contrast. So this mass has got few blood vessels in which that it can show contrast enhancement. So if I can just zoom this for you guys, you can clearly see over here this area has definite areas of blood vessels which is showing positive enhancement post contrast. So this is the blood supply of this mass over here. So this CT scan gave us even furthermore strong suspicion for a CA maxilla, because the CA, the cancer, is always very much full of blood vessels, and this mass showed post-contrast enhancement in specific few areas, mostly towards the periphery and here posterior towards the center, and mostly the periphery is showing enhancement. So we had a strong suspicion for CA maxilla. So but we did not go for a nasal biopsy. We just chose to go for the proper surgery, because assuming on this CT scan findings, endoscopy findings, and the patient's clinical profile, though the clinical profile did not match the findings of the CA, but the endoscopy findings and the CT scan findings did somehow giving a strong suspicion for the maxillary CA. But then we chose to do the patient's surgery directly without a biopsy, and following which we operated the patient. If you see the coronal section, it is full of double density sign, but not that of the allergic, but you can see a lot of vascular area post contrast region, and the entire left maxilla and the left nasal cavity is full of opacification. So when the patient we did a surgery on the patient, and we removed these bits of pieces, which was impossible for us to remove in total because of the fragmentation of the mass. So we had to remove that in fragments. So successfully removed the entire mass, and as you can see on the labeling over here, it shows the mass exceeds in pieces, and these masses were firm reddish with smooth surface. Okay, so intraoperatively we still did not have proper confirmation whether this could be maxillary CA or something else or any other vascular mass. But then the only confirmatory step here for a surgeon to diagnose it properly is the histopathology. So when the report of the histopath came in finally, it showed that you can see the proper 40 times magnification of the slide. It showed us the pseudostratified and ciliated columnar epithelium underneath the loose stroma with small vessels, hemorrhages with inflammatory infiltrate. So it is a hematoxylin EOS, so it's a normal H&E stain with 40 magnification power, and it showed a lot of loose stroma with small vessels. So the second histopath slide suggested something similar on 100 magnification. The same finding, pseudostratified ciliated columnar epithelial underneath loose stroma and small vessels. So when we discussed this case with the histopathological doctor, then he said that this more often looks like a the juvenile, not the juvenile angiofibroma, but it looks like an angiofibroma, but because of the patient's age and the extra nasopharyngeal site of origin, the origin being in the maxillary sinus, we concluded that this has to be a case of a extra nasopharyngeal angiofibroma seen in an old person. So the diagnosis was finally made as extra nasopharyngeal angiofibroma, not the typical one which you see in the juvenile cases, young adolescent males, which is called as the juvenile nasopharyngeal angiofibroma. These are different ones, though the histopathological features are almost similar to the JNA, the traditional JNA. but the sites of origin are quite different. Now, normally the JNA arises from the superior lip of the sphenopalatine foramen, but this extra nasopharyngeal angiofibroma, which is also similar in looks with the traditional JNA, like this, but they arise from any of the sites which is uh, extra from the sphenopalatine foramen. It could be the maxilla. The most common site for extranasopharyngeal angiofibroma is the maxillary sinus. Then it could be anywhere in the oropharyngeal cavity, tonsillar fossa. You can say it can also arise from the laryngeal area, the epiglottic area. It can also arise from the lacrimal sac, the conjunctiva, the nasal cavity, the hard palate, the soft palate. It can arise from any region given. So we just have to bear in mind that the mass may look firm, reddish. The patient may also have episodes of bleeding, and it may mimic a case of juvenile nasopharyngeal angiofibroma. So this case did not turn out to be a malignancy as we were suspecting it to be, but then on the biopsy we got to know that this case is a case of a angiofibroma. So it can occur at any age. Now this patient was really about around more than 60 years of age, an old patient, not even middle age, old patient. So this extranasopharyngeal angiofibroma is completely different from the traditional ones because they can occur at any age, they can occur in both the sexes, and if it occurs, it occurs in sites other than the sphenopalatine foramen, and as I mentioned, all the sites may be affected with the angiofibroma. But these patients, as the age progresses, it has more of the fibromatous component as compared to the angiomatous component, so it tends to bleed less as the age progresses because it undergoes fibrosis, so it keeps on getting firm and firm. Eventually becomes hard as the age progresses, and the bleeding becomes less. But the signs and symptoms, also depending on the location, varies accordingly. So if it's in the laryngeal region, it may have difficulty in breathing or difficulty in swallowing if it is present in the epiglottic area or in the tonsil or the oropharyngeal area. If it's present in the nasopharyngeal area or the nasal cavity, it may cause nasal obstruction, breathing problems. And as in this patient, the most common site is the maxillary sinus. This was coming from the maxillary sinus itself. So we had to operate on the patient. Surgery is the only option for treatment, and make sure that there is no residual of the mass left, because it could sometimes also lead to recurrence of the patient. So the moral of this video is that though the patient's age is kind of old, it mimics the history of a CA maxilla. Still, the 2 points which are more in the favor of CA maxilla, which is loosening of the teeth, and second is the facial numbness, or you can say the maxillary bulge, were absent in this patient. So nasal epistaxis, unilateral nasal obstruction, old age were the only points favorable in this patient, but eventually the mass turned out to be a case of a extranasopharyngeal angiofibroma, more towards the fibromatous changes and less of angiomatous because of the old age. So in young patients they also may occur. So the bleeding may be an issue in young children or the young females or middle-aged females, but this is a point to be taken home, is that never jump to a conclusion. Always get the histopathology of the patient done, and the CT scan is of most importance. Contrast was done because we were suspecting it to be a cancer vascular mass because of the epistaxis history. So all these points are very much necessary to understand the basic, the concept of narrowing down the differential diagnosis for a particular set of complaints or patient is having. So the patient's age, the patient's complaints, the history in which the pattern of the complaints are arising, and then the endoscopic findings, the CT scan findings, all need to be correlated. So it is actually called as the clinico-pathological radiological correlation, and then eventually you gotta confirm it on your histopathology. So to an end for the fourth case of OPD case discussions. Now I have 7 more cases which are ready, and they are all unique sinonasal masses, benign cases which requires thorough knowledge of ENT, especially of the nose and the PNS and the radiological aspect as well. So I'll be covering all those remaining 7 cases for you guys, and whatever patients I keep getting in the OPD or whatever cases I have, I will teach you everything and how you can deal with them in basic simple points. So till then, I'll see you next time with the case number 5 in my OPD case series. Till then, take care, guys.